Hello. Today we are not doing a what is COPD lesson. Instead, this is about what you do when the patient is in front of you. You are going to pretend you're on a medical surgical floor, you've gotten handover, and now it's on you to assess, prioritize, act, and know when to call for help. This case study is about nurse thinking, not just our knowledge, but also our judgment. Mr. Wren is an 85-year-old male from home. He's just been transferred from the emergency room to the medical surgical unit that you're working. The report received said that he came to the hospital because he has been having progressive shortness of breath over the past 5 days, accompanied by a frequent cough producing thick, greenish sputum, and he's also been feeling quite weak and fatigued. At home, he had been using a short acting inhaler more often than usual without noticeable improvement. His medical history includes chronic obstructive pulmonary disease, predominantly emphysema. He lives alone and uses a cane to mobilize, and he's still able to do his activities of daily living independently. He reported long term tobacco use over 30 years and currently smokes about half a pack of cigarettes daily. On arrival to the unit, he was able to walk with minimum assistance and he is fully alert and oriented to person, place, time, and situation. Physical assessment revealed an enlarged, rounded chest shape. Breath sounds were harsh with coarse crackles noted in both the lower lung fields and a wheeze heard mainly during exhalation. He was visibly using neck and chest muscles to breathe and tells you it feels like he cannot get enough air in. His fingertips are rounded and his nail beds are enlarged. His vital signs are as follows: blood pressure 148 over 89, heart rate 107, oxygen saturation is 89% on room air, respiratory rate is 30 breaths per minute, and his temperature is 36.8. This is a copy of the case study, and you could go ahead and take a screenshot for your reference. As the nurse, what do you suspect is happening? Mr. Wren's presentation is most consistent with an acute exacerbation of chronic obstructive pulmonary disease, likely triggered by a lower respiratory infection, the worsening shortness of breath, increased use of rescue inhalers without relief, productive cough with green sputum, wheezing, and use of accessory muscles all suggest airway inflammation, bronchoconstriction, and increased mucus production. The coarse crackles and change in sputum color point toward a possible pneumonia or bronchitis contributing to the exacerbation. Ongoing smoking likely worsens airway irritation and limits the body's ability to recover. When you first meet this patient, the first thing you should think is what is threatening life right now? For this patient, the top priority is impaired gas exchange, as evidenced by increased respiratory rate of 30, use of accessory muscles, abnormal breath sounds, productive cough with green sputum, and the patient's subjective report of difficulty taking a deep breath. These findings suggest that the lungs are not effectively moving oxygen in and carbon dioxide out. Tachypnea occurs because the lungs are trying to compensate for low oxygen or high carbon dioxide. The green sputum likely suggests an infection with worsening airway inflammation. Use of accessory muscles happens because there's increased work of breathing, and that patient saying that they don't have enough room to breathe, it's that subjective air hunger that should always be taken seriously. And then we have the expiratory wheeze and coarse crackles, which suggest airway narrowing. and increased mucus. COPD, or chronic obstructive pulmonary disease, is the overall name for a group of lung conditions. This includes emphysema and chronic bronchitis. In emphysema, the air sacs or alveoli in the lungs become damaged. This reduces surface area for gaseous exchange. In chronic bronchitis, the lining of the bronchial tubes in the lung become inflamed, and when this inflammation remains long term, it becomes chronic. Common symptoms of COPD include shortness of breath. This may only happen when exercising at first, but patients may also report waking up at night and feeling breathless. They also report a persistent chesty cough with phlegm that just does not go away, as well as frequent chest infections, persistent wheezing. The symptoms will usually get gradually worse over time and make daily activities or activities of daily living. The symptoms will usually get gradually worse over time and make activities of daily living increasingly difficult, although treatment can help slow the progression. Sometimes there may be episodes when symptoms get suddenly worse, and this is known as a flare up or an exacerbation. It is common to have a few flare ups a year, particularly during the winter. Other less common symptoms of COPD include weight loss, tiredness, swollen ankles, chest pain, and coughing up blood. And these latter symptoms could also be associated with other conditions. What are you worried about happening next for this patient? So he's having increased work of breathing, impaired gas exchange, and so we're worried about respiratory fatigue, hypoxia, CO2 retention, and respiratory failure. As the nurse, what is your priority action? And this is an NCLEX style question. A, encourage the patient to cough and deep breathe. B, place the patient in high Fowler's position and apply oxygen as ordered. C, obtain a sputum specimen for culture. Or D, teach pursed to lip breathing for long-term management. If you selected B, that would be the correct answer. Why? Because airway and breathing comes before teaching or diagnostics. Positioning and oxygen directly address hypoxia. Coughing and teaching are important, but not first. Once we see the respiratory rate and the O2, our brain should flip from assessing to intervening. This patient is not oxygenating well. Our priority would be to reduce the work of breathing, improve oxygen delivery, and this means positioning the patient upright, applying supplemental oxygen, followed by any other medications, such as what interventions should be included in the plan of care at this time. A, administer oxygen via a high flow nasal cannula. B, encourage slow pursed lip breathing during dyspneic episodes. C, apply continuous cardiac monitoring. And D, encourage use of the incentive spirometry. This question, more than one option would be correct. If you selected B and D, those would be the correct answers. This patient is experiencing impaired gas exchange due to an acute COPD exacerbation. Pursed to lip breathing will help prevent airway collapse during exhalation, improve ventilation, and decrease the work of breathing. Incentive spirometry promotes lung expansion, helps prevent atelectasis, and support better oxygenation. Now, high flow oxygen via nasal cannula would not be appropriate for a patient with COPD unless it is specifically ordered, and even then, we need to be careful because high concentration of oxygen can reduce to respiratory drive and lead to carbon dioxide retention or CO2 narcosis, particularly for patients who have COPD. Continuous cardiac monitoring might be used in some settings, but it does not directly treat our priority problem right now, which is impaired gas exchange. And so it would not be the most appropriate intervention at this time. This patient is hypoxic, they're working hard to breathe. Our goal is to improve ventilation quickly and safely. Choose interventions that open the airways and improve lung expansion without risking oxygen toxicity in a COPD patient. Which of the following are anticipated provider orders? A. Ipratropium and albuterol via an air chamber. B. Intravenous methylprednisone. C. Morphine for anxiety related to dyspnea. Or D. Ondansetron. A and B would be the correct answers. Bronchodilators such as ipratropium and albuterol reduce bronchoconstriction, while corticosteroids like methylprednisolone decrease airway inflammation associated with COPD exacerbations. Morphine is inappropriate because it can suppress respiratory drive in a patient who is already hypoxic. And dantrolene would not be indicated at this time unless the patient is having nausea or vomiting. Now, as a floor nurse, you are not managing this alone. Know who your resources are, know where they are, and know when to call for help. When a patient is hypoxic, they're working hard to breathe, they're needing frequent respiratory treatments, your respiratory therapist in your hospital or your setting will be a key resource. They can assess breathing patterns, adjust treatments, and recommend changes like switching delivery methods or escalating support. And you do not have to wait until the patient is in an acute condition or their clinical status has changed in order to alert the RT that you have this type of patient on your floor and you're taking care of them. Pharmacy can help with bronchodilator timing, steroid dosing, and antibiotic choices. Your charge nurse will help with workload and escalating decisions, and as well keep your most responsible provider updated on the patient's clinical conditions. What tests and labs might be ordered and why? So this isn't just about treating symptoms. You need to know what is causing the exacerbation. And so a respiratory panel might include COVID, influenza, RSV, and will help to rule in or rule out viral causes of the exacerbation. A sputum culture and sensitivity will look for bacterial sources, and a blood culture might be ordered if the patient appears systemically unwell. A chest x-ray checks for pneumonia or other complications. And then we have our arterial and venous blood gas will help to assess oxygenation and carbon dioxide levels and ensuring that you are comparing any new arterial or venous blood gas results with that initial result that you received. As the shift goes on, what changes would make you more concerned? Now, this is a point where you're watching for a respiratory failure. So if you notice increased work of breathing, rising CO2 levels as evidenced by worsening ABGs, decreasing oxygen saturation despite oxygen that you're applying, fatigue, decreased level of consciousness, they might have come in with a GCS of 15 and now their GCS is 12, or they're having inability to clear secretions. This case isn't about memorizing what COPD is. It was about what you do when the patient is in front of you. You assess what matters, identify your priority problems, act on breathing first, use your resources, watch for deterioration. And every shift is not just about following orders, but constantly thinking, prioritizing, and protecting your patient. This kind of thinking is what will make you a safe and competent nurse. Thanks for watching. Stay tuned for more videos like these. Remember to like, comment, share. You can also comment of topics you'd like us to discuss here. Thank you.